Trauma Therapist Podcast, episode 521. All right, welcome back to the Trauma Therapist Podcast. My name is Guy McPherson. My mission is to raise the awareness of trauma and to support and inspire new trauma therapists just starting out on the trauma-informed journey. I do that with my membership community, Trauma Therapist 2.0, my online courses and workshops, and the Trauma Therapist newsletter. If you're a therapist of any kind and you work with individuals who've been impacted by trauma, I invite you to head on over to my website at thetraumatherapistproject.com. That's thetraumatherapistproject.com. All right, let's get started. You ready to do this?
Mm-hmm.
Okay. So 5, 4, 3, 2, and 1. All right, folks, welcome back to the Trauma Therapist Podcast. Today, I am very excited to have as my guest, Dr. Lorry Leigh Belhumeur. Lorry, welcome.
Thank you so much. It's great to be here.
All right. So Lorry is a licensed psychologist serving as Chief Executive Officer at Western Youth Services for over 19 years. She received her PhD and MA degrees from UCLA. Under her leadership, WYS provides integrative mental health services to over 50,000 clients, both directly and indirectly, with support from their collaborative partnerships. As a seasoned community leader and fierce advocate for children, Lorry brings a fresh approach that reexamines mental health in context of adverse childhood experiences and offers solutions that not only treat the predictable negative impact of ACEs, but that look upstream to prevent them from happening in the first place. All right, Lorry, just obviously a brief snippet of you and what you're about. But before we get going here, share with our listeners where you're from originally and where you're calling from currently.
Well, I grew up in San Diego, California, and I'm just up the road in Orange County, California, in Laguna Hills is where our main office is.
Nice. Okay. So let's start out here. I mean, seriously, the reason why I started this podcast was to speak with people like yourself who really have been doing this and are passionate about helping people who've been impacted by trauma. Yeah. How did you get into this field?
That's a great question that I'm often asked. And it's really, I think if I look back on it, I knew, early on that I was sort of wired to help people. And, went into college as a nursing major, switched it to psych, and just knew, I think when I got into the field and specifically working with children, I think it was really motivated by my desire to heal my own wounds, but also to be a beacon for others who wanted to do the same. So It's really about sort of that lifelong learning process and wanting to bring others along in the healing process.
When you talked about your own wounds, was that conscious for you when you started doing this?
Yes, actually it was conscious, like knowing that home for me was not a safe place. And so there were, physical and emotional wounds that were a result of that experience. And so it really was, even in thinking about going in as a nurse, it was going to be a psychiatric nurse, because I just knew that emotionally, there was something to be said about the mental health needs and now I refer to mental wellness needs that we that we all have.
All right, so let's continue on here. So you get in, you started nursing. Did you go through school or what?
I went into college as a nursing major.
Okay.
and realized very early on, I don't know why I knew this, like I hate science, or I did. I like being a scientist, but I didn't like biology and microbiology and organic chem, and it just bombed, which was really unusual for me. And I had, one of the things that'll be a theme is that I have mentors and that I had people who really believed in me. So there was the dean of the college of the small college, and also the head of the psych department, same person, said, gosh, have you considered a degree in psychology? You're having a real little trouble here with the sciences, but you're doing really well in psychology. Have you thought of changing your major? And by junior year, I had done that. And I knew when I changed my major, going for a PhD. Like for me, it was like early on, that was the trajectory. So.
All right. So you go through that program. How
Mhm.
does um or when? How and when do you say, okay, I'm interested in trauma, I'm interested in working with kids and so forth. Tell us
Well,
about that.
I were early. I was really privileged, blessed. I call it, to be able to work in a hospital while I was in undergrad on a psychiatric unit, and then when I graduated with my bachelor's degree, I um, I went into graduate school at the same time I was working, and I worked at an inpatient psych unit for youth.
Mm.
And that was really, so I was, right after my bachelor's, before I went to UCLA, there was a little gap year where I was enrolled in graduate school, but waiting to get into UCLA, so to speak. And it was that year that I worked in that inpatient psych unit with kids. And I said to myself, I mean, I was in my early 20s at that time. These kids were 16, 17 years old. And I was thinking, my experience was not far off from these kids.
Mm.
And here I am, just a few years older, um, and just a little bit farther along the healing process. And it was that in my early 20s when I knew that I was really gravitating toward youth.
In my previous position, I was working in Northern California at a facility where we assessed and treated young individuals who were showing early signs of psychosis. And a
Mm,
lot of those kids, a lot of those young
mm,
individuals were in and out of
yeah.
those types of facilities. So I can feel, I had a very different idea of what that population
Mm,
was
yeah.
before I started working with them.
Mm,
Can you what was it like for you? I mean, you said, you were very conscious of your own experiences, your
yeah.
own traumas, and now here you are working with these kids. I'm sure many of them have experienced trauma. What was it like for you?
In working with that population initially, well, I think it was that. I think it was, you're reading, especially in inpatient. There was also some outpatient work, later on, and working with adolescents. My private practice at the time sort of really it became working with adolescents. It was just like, I didn't set out to do it exactly, but that's sort of who was referred to me. So I think that the connection was looking at the histories, reading through the histories. There was a lot of trauma, no matter what the symptoms were or what the diagnosis was for these kids in the hospital or in private practice, whether it was depression, anxiety, some degree of psychosis. The running theme was really trauma in the past of some sort. Yeah.
Was that triggering for you at all in any sense?
Well,
Was
of course,
Yeah.
of course it was. And I think that that is one of the other points that I like to make, is to make sure that we're ahead in our own healing process uh, than than our clients, obviously. And we have a responsibility to make sure that we are addressing any countertransference or anything that's coming up or triggering for us.
Mhm.
So, fortunately, I had really, really good supervisors who knew, and I was able to tell them about my own past experience. And so I think even today, in a role where I'm not a direct service provider, I'm not, I don't have a private practice anymore, but I do serve administratively as the
Mhm.
CEO. And, there are things that come up, even today, that are triggering. And so it's just a matter of, what do we do with that information, and have tools and resources and practices that we have to make sure that we're addressing those things.
Right.
Um, I think to also make a connection, something that was really significant in looking at the trauma, and understanding the impact of trauma and on the potential for mental health conditions in children and then in adulthood, is really, as you mentioned in my bio, the research around adverse childhood experiences. And so I don't know if you want me to go into that right this second, but adverse childhood experiences specifically, that term came from some research in the late 90s. And it's 10 specific adverse childhood experiences that sort of make up this body of research and literature. And it was looking at that research and literature in the context of also my own experience, and saying, gosh, there's really, it gives us a common language to use when we're talking to parents, or if we're talking to teachers, or when we're providing mental health services for kids, that it gives us a language and terminology to talk to teachers and other people that really allow them to connect the dots easier. When you're talking about ACEs and the connection between ACEs and the risk for mental health conditions, it's just it's easier to have a conversation about that. And there's lots of data that we can, and literature that we can point to, that kind of put the puzzle pieces together.
Right. So how long now have you been working with WYS?
Well, I've been in this role, actually it'll be 20 years
Wow.
this month that I'm in this particular role.
Okay.
And a few more, a few years before that, as a psychologist as well.
Okay. So let's kind of, before we get into WYS, can you share kind of an early clinical error?
Oh gosh. I really like telling this story because, when we're young practitioners, or early in our career, whether we start anyway, early in our career as therapists, obviously, we want to say the right thing. We want to do the right thing. We've, taken a lot of classes. We have a lot of book knowledge. We have supervisors. And so I remember, having a supervisor where I'd go into the supervisor and I'd say, I said this or that, I said this particular thing to is that okay? But the story that I really like to share is when I was pregnant, and I had a teenage client that I was seeing, and the mom was also pregnant at the same time. And so afterwards, after maternity leave, the mom comes in and says, so now that you've had a child of your own, is your perspective any different? And so inside, I was like, okay, what is the book? What does the supervisor say I should say? So I made sure that whatever my response was felt clinically appropriate. But the error was, afterwards, my countertransference was, what on earth was I possibly thinking? Like, how presumptuous of me to think that I could even be a therapist for parents, before I had kids of my own. And so, so I think when I look back on it, it's like, so often we want to respond early. We want to respond with our book knowledge, or what am I supposed to say, kind of. And really, what it is be authentic and genuine, be yourself, in the therapy process, and be genuine, be authentic, because that gives the freedom for our clients to do the same. Mm-hmm. And so I think that the error was that, in retrospect, that I really wanted to rely on the book knowledge. What am I supposed to say in this situation right now, versus what do I want to say, and how can I make that, how can I build the therapeutic alliance by being genuinely and authentically me? Mm-hmm. That makes sense?
Yeah, it does. I appreciate you sharing that. Was that the journey to that authentic self, in a sense, and being able to own that authentic self within therapy context? I was just gonna say, what was that like, that journey to get there, in a sense?
Oh, that's a really good question. I think it really was, because that event really highlighted like, what can, this question is still the same. Like, what can I say or not say, based on that, and that yielded the question of going to the supervisor, like, oh, I said blah, blah, blah. And every single time he said, Lori, it's okay. Like, like,
Right.
really, it's okay. He never came back and said, oh my gosh, you should not have said that. It was always like, but I think it was, for me, that's a really good question. The authentic part of it really was realizing that whatever the experiences are, whether it was motherhood or any of the other things that were happening to me in my life as an adult, as a therapist, that those experiences and my own healing through adversity, and even the adversities that I experienced, in my life, in my career, and even today, it's how do I integrate that healing and learning into who I am as a person that would allow me to be a better therapist, a better
Mhm.
leader, a better, whatever the role is. So I think, uh, you know, in retrospect, I think it was really a turning point for me where I wanted to be able to say what my own experience was authentically, not just what does the book say or what does my
Right.
supervisor say I should be saying.
Right. Right.
Yeah.
Yeah, that makes a lot of sense. I mean, that's awesome. It just really feels like, trying to connect as a human being
Yes.
rather
Yes.
than having the book sitting between you and your client in a sense,
Right.
Um,
Or even the literature or the research or the whatever,
mhm,
like all of those things. I'm a data geek, a data, I like research. I like information. And so it's how to take in all of that information and then be,
right.
integrated in a way, but still be authentic and genuine
Right.
and all
Yeah.
of those things.
Awesome.
Mhm.
All right. So, how did you, in what capacity did you land at WYS?
So I actually came here as an unlicensed psychologist before I was licensed. I got licensed while I was here. I took what I call a hiatus after I was licensed and then came back as a licensed psychologist, later program director, and directed multiple programs throughout the organization. And then again, 20 years ago this month, promoted into this role as CEO.
Okay. And so WYS, Western Youth Services, what do you folks do in a nutshell?
In a nutshell, we provide a full range of integrated mental health services for kids and families. And the full range includes early intervention, prevention services, early intervention, targeted, intervention specifically to meet the needs, but then also outpatient services for kids that have diagnosable mental health conditions. So really in the bio, we talk about the upstream work. So
Mm-hmm.
uh, as we've been experts in providing direct mental health services with licensed and licensed eligible mental health service practitioners, we became aware of a lot of those situations and precursors. So we started to work upstream. What are those root causes of those things? Let's see if we can get in and prevent them from happening in the first place. And again, that's where the ACEs literature comes in terms of really targeting and addressing those adverse childhood experiences that put kids at higher risk for mental health conditions.
So what does that look like specifically? How are you doing that?
Well, what we're doing is here's an example. We go into a school district, we have a contract with the school district, and we go in and we provide, well, when we were able to provide services in person, it would be like a lunch club. It would be a
Okay.
classroom where kids come in and have someone there who's giving them, life lessons about empathy, about sharing, about leadership, youth leadership, about, just those things that those protective, building the
Mm-hmm.
protective factors that really buffer the adversity. So it's programs that are designed to really build protective factors, social connections, things that are associated with better outcomes.
Hmm.
And so it's, in the schools where we're providing prevention programs of every sort. We also have other evidence-based curricula that we work with teachers and students and We use, like, for example, zones of regulation that gives, uh, an opportunity for students to identify, here's where I feel emotionally right now. I'm emotionally ready to have a conversation. No, I need to wait an hour. I need to wait a day, so that there's, so it's working with teachers and principals to build, social and emotional learning programs for kids. So that's sort of the upstream work that we do. And it's also parenting classes, things that again are really working indirectly with the families. And then we also provide behavioral health training to the community. So on topics such as resilience and ACEs and um, growth mindset, things again that build those protective factors. And then the other end of the spectrum is that we provide direct mental health services through mental health practitioners for kids that have diagnosable mental health conditions, that have depression, anxiety, PTSD, and where we're providing evidence-based mental health intervention for those kids individually, weekly, individual. Now we're doing it telehealth, predominantly through telehealth, and providing direct mental health services, counseling.
Wow.
Yeah, wow.
That's huge.
That's why it's so many. There's
is
so many kids, directly and indirectly that we get to really help change their trajectory, for the
Yeah.
future.
Wow. So, you've been doing this a while. Can you point to, and this might be hard to articulate, but can you point to any shifts in your clientele, the population you're dealing with? Years ago, adolescents.
That's, the way for me to answer that, I think right now, is to put it in the context of the adversity that we're experiencing, through the pandemic and things of that nature right now. I would say that there is right now, or before COVID, the number was 1 in 5. 1 in 5 kids have a diagnosable mental health condition. That's a nationwide statistic. That's 20% of kids have a diagnosable mental health condition. Like, that number is like mind blowing in and of itself, right? And what we know is access to care is, only about 30% of those kids have access to care or resources, that would help that. So for us, the shift has been, again, over the last, I'm going to get back to the COVID part of the question, but I was thinking that, for us, the shift has been what I just described, which is the shift from providing direct mental health services to kids with diagnosable mental health conditions to really looking what's the upstream work. So our work has shifted to providing resources for kids to prevent the mental health conditions from happening in the first place, or at least buffering them and building protective factors to reduce the risk. But what we've seen recently is such an increase in the acuity, the severity of the depression and the anxiety and what looks like PTSD and those things. Like, the number of kids that we have in our care that are at high risk right now is more than before. And if you think about it, kids had access to, they hung out with their friends at school. They had a social network and connection. They could be with their friends. They could also have, mentors and other people who were, working directly with them and could see them and give them hugs and, just different things that they're really lacking right now as because of the physical distance, because they're not in the classroom, because they're not in their social activities such as sports and things like that. So I think that making a connection between sort of the level of risk and acuity of kids is a little bit higher now than pre-COVID.
Are you When you're looking for, say, interns or
Mm.
license eligible clinicians, what are you looking for?
Oh gosh, that's another good question. What we're looking for, I'm going to be really honest. One of the things that we're looking for is an attitude of service. Like the population that we serve are kids that are in marginalized communities. They are, um, you know, uh, our services are provided through Medi-Cal funding, and so we're providing services to kids and families that have low income levels. They're in densely populated neighborhoods. And so we're really looking for an attitude of service, like
Mm-hmm.
that there's a heart for this particular community, which is different than someone who gets out of graduate school and wants to go in private practice. It's really a different, it's a different act of service. And so I think that's one of the main things, teachability, coachability, those things like willingness to learn. Um, and and also some experience, because we're a children's services provider, some experience with children,
Mm-hmm.
also is what we look for when we're hiring in.
Yeah, I was just thinking about when I was looking for an internship. I mean, oftentimes you're like whatever you can get, you
Yeah,
know.
right.
But yeah, it's so awesome. I love what you're talking about, and I love your description of all the services you offer. And that's a very similar population that I was working with in Contra Costa County.
Mm,
Our facility was, through Medi-Cal and so
right,
forth,
right.
and it was very, very challenging, but just so needed and
Mm,
necessary. And especially with your, the statistic you cited, which was 1 in 5 kids. It's crazy.
that is, that's an outrageous number. It really, really is. And that is, again, like, well, to tie it back to ACEs, what we really believe is that we can move the needle from 1 in 5 to 1 in 10 in this generation. We believe that we can do that because there's a direct connection, a high correlation with number of ACEs and risk for mental health conditions later. So if we're
Mm-hmm.
intervening in,
Mm-hmm.
second and third and fourth grade, when we know that most mental health conditions, the majority, the onset is by age 14. So, and if we know that ACEs makes a connection with risk, and we can go in and buffer families and reduce the impact of the ACEs and
Right.
also reduce the ACEs, the future of them, we believe that we're going to be able to make a massive impact and change the trajectory of these kids' lives.
That's awesome. All right, Lori, as we kind of wind down here, can you share a go-to book
Mm,
recommendation, whether, ACEs related or not, or
yeah.
trauma related or not?
You know what? I have it right here. Here in California, Dr. Nadine Burke Harris, who's like sort of the champion for the ACEs movement and really looking at ACEs as a public health crisis, right? She's now the Surgeon General of the state of
Mm-hmm.
California. Her book is The Deepest Well. I literally have my books that I'm in the process of reading here at the office, like my nightstand. I have them here. And I knew you were going to ask that question. So I just pulled it right off
Nice.
here. So The Deepest Well, healing the long-term effects of childhood adversity. So that's what I recommend, because again, it gives us, ACEs gives us a language that we can talk about,
Mm-hmm.
in terms that we understand, and connect the dots to the hope that's out there and available to these kids. So having that adversity, having exposure to that trauma is not a life sentence,
Mm-hmm.
toward, a lot of the other risk factors. It's really, the fact that we can make a difference and um, buffer the impact of ACEs is is what brings hope to the
That's
next
awesome.
populate
That's
next
awesome.
generation. Yeah.
All right. So what's the best way for people to get in contact with you, Lori?
Well, the website for Western Youth Services is westernyouthservices.org. And so you can get in contact with me through the website, and you can also see some of the resources that we have available, here locally in the community.
Okay.
But we also have something called the Reset Toolbox. So that's resilience, essential social emotional trainings. And it's through the website, but resettoolbox.com or .org. And there's lots of resources. So we've done the vetting for the resources, the mental health resources for kids and families. And so they're all in that toolbox. You can access that through the website as well.
Okay. So it's for clients.
It is. It's for
Okay.
clients,
Okay.
teachers. It has like a little feature there. You say, I'm a community member, I'm a teacher, I'm a student, I'm a
Okay.
parent. And it has apps and books
Awesome.
and resources and all kinds of links to things that are out there that are helping kids right now.
Awesome. All right. I'll have that linked up at the show notes page at the Trauma
Great,
Therapist
thank
podcast. Yeah, you're welcome. All right, Lorry. Awesome. Well, inspiring, man. I love talking to you and really appreciate the work you're doing. I know how valuable it is.
Oh, thank you so much, Guy, for the opportunity. And I look forward to talking again in the future if the opportunity comes up.
All right. Take care.
All right. Thank you so much.